Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Bayer.
Hello and welcome to the third and final episode of this season's Thrombosis TV, addressing common challenges in anticoagulation in atrial fibrillation when a patient needs a procedure. I'm Susan Mayer. The predominant challenge in managing anticoagulant therapy in patients with atrial fibrillation is balancing the risk of stroke with the risk of bleeding. In episode 1, we discussed how underusing and underdosing non-vitamin K oral anticoagulants, the NOACs, to reduce bleeding risk in patients with atrial fibrillation significantly increases the risk of stroke. In this episode, we look at another challenge in balancing stroke risk and bleeding risk in patients with atrial fibrillation, how to adjust NOAC dosing before, during and after a surgical or medical intervention. Our focus is on elective interventions that are associated with relatively low risk of problematic bleeding events, rather than emergency or major surgical interventions associated with very high risk of serious bleeding, where the use of specific NOAC reversal agents may be considered. To get the latest guidance and perspectives for addressing this challenge, I met with Dr. Tatiana Potpara, head of the Department of Intensive Care in Cardiac Arrhythmias at the Cardiology Clinic at the Clinical Center of Serbia in Belgrade, and Assistant Professor of Internal Medicine and Cardiology at the School of Medicine at Belgrade University. Good morning, Tatiana. Thank you for participating in our program today.
Good morning, Susan. My pleasure.
Overall, what is your approach to maintaining safe and effective NOAC therapy in patients with atrial fibrillation undergoing an elective surgical or medical intervention that may cause a problematic bleeding event?
First, we need to distinguish between the challenges that are real and those more related to patient and physician perceptions. There are numerous elective surgical and medical interventions ranging from, for example, removal of a skin lesion, tooth extraction, elective percutaneous coronary intervention, to hip replacement surgery. And the decision whether to discontinue or adjust the dosage of a NOAC before, during, and or after the intervention depends on the level of invasiveness and bleeding risk. And assessment of bleeding risk is based on the potential clinical impact associated with the intervention. In addition, certain patient characteristics such as age, kidney function, history of bleeding issues, comorbidity, concomitant medications also factor into the decision. In general, guidelines recommend against discontinuing NOAC for most minor or low bleeding risk interventions. However, dosage adjustments may be appropriate depending on the level of bleeding risk, time of the surgery, and prescribed dosing schedule of the NOAC. In contrast, high bleeding risk interventions, such as major surgery, often require discontinuation of NOAC therapy for 1 or 2 days before the procedure through 1 or 2 days after the procedure.
You mentioned elective interventions that are associated with a minor and low bleeding risk. Can you provide examples of these types of interventions and their associated recommendations for adjustments in NOAC therapy?
A widely used practical guide for the management of NOAC therapy in patients with atrial fibrillation, including those undergoing an elective intervention, is published by the European Heart and Rhythm Association. And the ERAS document classifies elective interventions into three categories of bleeding risk: minor, low, and high, based on the frequency of bleeding and its potential clinical impact on the patient. Common examples of interventions portending a minor risk of bleeding include most dental procedures, cataract and glaucoma surgeries, endoscopy without biopsy or resection, and superficial skin excisions. Common examples of interventions classified as having a low risk of bleeding include endoscopy with biopsy, uncomplicated catheter ablation of cardiac arrhythmias, and non-surgery, non-coronary angiography. Uncomplicated pacemaker and defibrillator implantations would also be classified as having a low bleeding risk. As a rule of thumb, elective minor and low bleeding risk interventions can be performed 12 to 24 hours after the last NOAC dose. On the other side of the equation, NOAC can be restarted 6 hours after the intervention, as long as the patient has achieved adequate hemostasis.
Let's say a patient on NOAC therapy for atrial fibrillation is undergoing an elective intervention associated with a minor risk of bleeding. What determines whether a dosing adjustment is necessary?
Well, for elective minor bleeding risk interventions, no changes in NOAC dosing are necessary on the day before and the day after the procedure. On the day of the intervention, however, dosing adjustments would depend on the time of the day, whether the NOAC is dosed once or twice daily, and if dosed once daily, whether the patient is routinely taking the daily dose in the morning or evening.
Can you be more specific about the recommended dosing adjustments for each of the 4 NOACs for a minor bleeding risk intervention? Let's say the intervention is scheduled for the morning.
Well, for the bigatron or apixaban, which are dosed twice daily, the patient would take only one dose on the day of the intervention, at least 6 hours after the procedure. For rivaroxaban and edoxaban, which are dosed once daily, the daily dose would be administered regularly in the evening or at least 6 hours after the morning intervention in patients regularly taking their NOAC in the morning.
OK, what about interventions associated with the next category of bleeding risk, a low risk of bleeding? What are the dosing adjustment recommendations for the 4 NOACs for these types of interventions? Once again, let's assume the intervention takes place in the morning.
The major difference between minor and low bleeding risk interventions is that the latter may require a NOAC dosing adjustment the day before the procedure. For twice daily dabigatran and apixaban, the patient would skip the evening dose the day before the intervention, skip the morning dose the day of the intervention, and restart the evening dose at least 6 hours after the intervention. For once daily rivaroxaban or edoxaban, the dosing adjustment again depends on when the patient routinely takes their daily dose. Patients who take their daily dose in the morning would take it in the morning the day before a morning intervention, but postpone the next dose until at least 6 hours after the intervention. Patients who take their daily dose in the evening, which is the recommended timing for rivaroxaban, would skip the evening dose the day before a morning intervention and resume the evening dose at least 6 hours after the intervention.
Would impaired renal function associated with chronic kidney disease impact the recommended dosing adjustments for interventions associated with a minor or low risk of bleeding?
It depends on the NOAC. For the bigatran, which is 80% excreted by the kidneys, graded increases in the amount of time between the last dose and the start of most elective low bleeding risk interventions are recommended for patients with a creatinine clearance under 80 milliliters per minute. For other NOACs, the dosing guidance is the same for patients with a creatinine clearance greater than 30 milliliters per minute, but the amount of time between last dose and the intervention is increased for patients with a creatinine clearance below 30 milliliters per minute.
What happens if a patient undergoing a minor or low bleeding risk elective intervention experiences a problematic bleeding event? How would that affect the resumption of NOAC therapy after the intervention?
Well, local chemostatic measures are usually sufficient to resolve most bleeding issues resulting from a minor or low bleeding risk intervention. However, the patient should not leave the clinic or hospital or resume oral anticoagulant therapy until all peri-interventional bleeding has been completely stopped.
One of the low bleeding risk interventions mentioned by Dr. Potpara is percutaneous coronary intervention. Many patients with atrial fibrillation also have or may develop coronary artery disease and will require PCI at some point while on anticoagulant therapy. Although the intervention itself is associated with a low bleeding risk, PCI presents a challenge because it requires extended post-procedural antiplatelet therapy to prevent a recurrent coronary ischemic event and stent thrombosis. And we know that concomitant anticoagulant and antiplatelet therapy significantly increases bleeding risk. I asked Dr. Potpara what her approach would be to managing NOAC therapy in patients with atrial fibrillation who undergo elective PCI for chronic coronary artery disease rather than for an acute event.
Patients with atrial fibrillation who require a PCI for symptomatic chronic coronary artery disease present a complex clinical scenario on several fronts. One is that they tend to be older and have underlying comorbidity such as hypertension or diabetes. So these patients are at increased risk for stroke due to their atrial fibrillation and increased risk of a coronary ischemic event due to their coronary artery disease, and an increased risk of anticoagulant and antiplatelet therapy-related bleeding due to their age and underlying comorbidity. Although there is a range of options in terms of the intensity and duration of antiplatelet therapy after PCI, an absolute in patients with atrial fibrillation is the need to maintain anticoagulant therapy at a recommended dosage to prevent stroke, as either P2Y12 inhibitors or aspirin or even their combinations would not provide optimal protection from AF-related stroke, which is why AF patients must continue their anticoagulant therapy. On the other hand, NOACs are not sufficient in themselves to protect against coronary ischemic events and stent thrombosis, which is why antiplatelet therapy is recommended after PCI. The decision involves whether to administer a P2Y12 inhibitor or aspirin or both, and for how long.
What's the clinical evidence up to this point on the efficacy and safety of NOACs in combination with antiplatelet therapy after PCI in patients with atrial fibrillation and chronic CAD?
Several randomized clinical trials have compared dual and triple therapy, including an oral anticoagulant, be it a vitamin K antagonist or a NOAC, in combination with a P2Y12 inhibitor, so-called dual therapy, or with a P2Y12 inhibitor and aspirin, so-called triple therapy, in the management of AF patients with either an acute coronary syndrome or chronic coronary artery disease undergoing a PCI. Although some uncertainties remain, a few conclusions have been reached from those trials. One is that dual therapy with a NOAC and a P2Y12 inhibitor, specifically clopidogrel, is associated with significantly lower risk of major and fatal bleeding events as compared with triple therapy with warfarin, clopidogrel, and aspirin. There was no significant difference in the risk of myocardial infarction, stent thrombosis, stroke, and mortality between dual and triple therapy in either of the 4 randomized clinical trials. But these trials were not powered for the assessment of ischemic events, and several meta-analyses of the randomized clinical trials reported conflicting findings ranging from no difference in ischemic events with dual versus triple therapy to increased risk of myocardial infarction or stent thrombosis with dual therapy, but increased risk of intracranial hemorrhage with triple therapy, especially with warfarin. In addition, those trials showed, as well as meta-analysis did, that NOACs were safer than vitamin K antagonists in any combination they were used. Hence, the area of controversy centers on whether there is a net clinical benefit of adding aspirin to dual therapy, so using so-called triple therapy, and if so, for how long after a PCI.
What does the latest clinical trial evidence suggest?
But overall, the decision of whether to prescribe a course of triple therapy after PCI and for how long, for example, until discharge or for a week or even longer, needs to be individualized based on the patient's relative risks of a critical ischemic event and major bleeding event. Of note, patients in all pertinent randomized clinical trials were taking triple therapy for at least the day of the PCI or until randomization to dual or triple therapy.
You mentioned clinical trials supporting the use of clopidogrel in combination with NOACs in the treatment of patients with atrial fibrillation undergoing PCI. Is there any evidence supporting the efficacy and safety of other P2Y12 inhibitors in combination with NOACs?
To this point, clinical trials evaluating combination of anticoagulant and antiplatelet therapy in patients with atrial fibrillation after a PCI have not included a sufficient number of patients using ticagrelor or prasugrel to draw any conclusions about their relative safety and efficacy. But one would expect that there may be more bleeding with a more potent antiplatelet drug.
Earlier in our conversation, you mentioned the importance of distinguishing between interventions that involve a real risk of serious bleeding and those that are more related to patient and physician perceptions. Do you find that the perceptions of patients and physicians have an impact on the management of atrial fibrillation during elective interventions?
Oh, yes, they do. Those of us who regularly see patients with atrial fibrillation clearly understand the net clinical benefit provided by oral anticoagulant therapy, despite the associated increased risk of bleeding. However, although stroke is one of the most catastrophic medical events that can befall a patient, oral anticoagulant therapy benefits a patient by reducing the risk of an event that has not yet happened and may never happen. In the meantime, anticoagulation-related bleeding, even if relatively minor and manageable, happens in the present, may be very upsetting for many patients, and is related to a drug they are taking. So there can be a tendency for patients to underdose or even discontinue their NOAC in anticipation of a procedure to avoid unpleasant bleeding, especially if they have experienced a bleeding event in the past. For this reason, it's important for clinicians to understand their patients' perceptions of their condition and their self-perceived treatment burden, so that they can more effectively communicate with their patients and ensure their adherence to dosing guidelines. Although NOACs have significantly reduced patient-perceived bleeding risk compared to vitamin K antagonists, concerns about both minor and major bleeding events can still be a barrier to adherence for many patients.
Tatiana, we're almost out of time. Do you have any key take-home messages for our audience pertaining to our discussion?
In navigating the balance between stroke prevention and bleeding risk in patients with atrial fibrillation undergoing an elective intervention, it is essential to realistically evaluate the potential positive and negative consequences of NOAC dosing adjustments. Decision on peri-interventional NOAC dosing adjustments should be based on the bleeding risk associated with the intervention, specific NOAC label, and an individualized assessment of a patient's relative risk for stroke and bleeding. If the patient is undergoing a PCI, the risk of coronary ischemic events and the consequences of intensity and duration of antiplatelet therapy also need to be factored into the decision.
Thank you, Tatiana, for taking part in our program today.
Thank you, Susan.
This concludes the final episode of this season's Thrombosis TV. We hope you found this episode, as well as the entire series, to be informative and relevant to your practice. To proceed to the online CME test, click on the Earn CME credit link on this page. And thank you for watching this program.